Okay, everyone, I realize a lot of people are still trickling in, but we're running a little bit behind time, so I think it's critical that we get started. And we were very honored earlier this morning to hear a fantastic presentation about the National Plan to Address Alzheimer's Disease by Dr. Ron Petersen, and we were able to tap him in to do double duty. Since we're a little bit behind time, I'll just go through very quickly and describe some of his accolades. He's the CADU director of the Mayo Alzheimer's Disease Research Center. He's a distinguished professor at the Mayo Clinic. He holds the Carnell Professorship in Alzheimer's Disease Research. He has just been a true pioneer in the field in terms of redefining our understanding of dementia and the prodromal forms of it. He has published over 400 papers throughout his illustrious career. As we heard earlier, he was chairing the panel to come up with the National Alzheimer's Plan, and he also serves as the chair on the Alzheimer's, he's also a member of the DSM committee to redefine dementia. And so without any further ado, let me welcome Ron back up here.
Thanks again, Frank. It is fun to come and talk about this topic, although it's been variably received by the professional field, and I'll get into some of that this afternoon. So that nobody else in this room is surprised, I'm now in the witness protection program of the APA because we try not to admit that we were involved in this activity. But most of you know what DSM is all about. It's a Diagnostic and Statistical Manual of Mental Disorders, and it's really the sort of the Bible for psychiatrists, but it spills outside of psychiatry, actually, insofar as it dovetails with the ICD-9, the International Classification of Disorders, 9th version, 10th version underway, being rolled out, and then ICD-11, which will follow, which will more closely reflect what DSM-5 says. Why is ICD important? Because this is the coding manual that basically prescribes who gets paid what for their actions. So when all of us code a certain diagnosis for a patient, it gets translated into an ICD-9 code, and that determines dollars and cents. So while DSM-5 does not do that directly, it's closely aligned, and ICD will draw upon DSM for many of its categorizations of disorders. So it does have an effect beyond just psychiatry. It was put together by the American Psychiatric Association, but in fact is a worldwide document, since many other countries also use these diagnostic formulations. So with that as a backdrop, then, let me just talk about the specific aspects of DSM that are relevant to what we were talking about this morning. These are the same disclosures, haven't changed since this morning. This is the group of individuals who were on what was called the Neurocognitive Disorders Work Group. They're all psychiatrists. Jane Paulson is a neuropsychologist, and I was sort of the token neurologist, I think, for affirmative action or something like that. They had to have somebody on the committee. So, DSM-5, neurocognitive disorders. This was a newish description of these disorders for DSM-5. Previously, it had been delirium, dementia, amnestic, and geriatric cognitive disorders was the group and the disorders. And the new definition, neurocognitive disorders, was meant to emphasize the fact that cognition is really the core deficit involved, and these represent a decline from a previous level of functioning. And that was meant to set aside any developmental disorders. So we're not dealing with developmental disorders here. That's covered elsewhere in the manual. This was acquired disorders. There were three conditions, essentially. The whole chapter, if you will, was boiled down to three conditions: delirium, major neurocognitive disorder, and mild neurocognitive disorder. Note it's mild, not minor. I think Dr. Fleischer this morning had minor on it. In some of the earlier versions of this, it was called major and minor, and we were discouraged from using the term minor because third-party payers may not reimburse for a minor disorder, believe it or not. The companies would say, no, if it's minor, I'm not going to pay for it. So we had to take that term out, and we substituted mild for that. I won't say much about delirium, but just for completeness, just want you to know that there were very slight changes in the construct of delirium with regard to DSM-5. So what is delirium? A disturbance of attention and awareness, change over a short period of time. So as opposed to dementia, which evolves over usually months or more, delirium happens quite abruptly. It includes a disturbance, though, in cognition because people are not thinking quite well and not explained by other conditions. So it wasn't that it was whatever you had before is now getting worse. No, this is a change or a different condition. And it's usually caused by a physiologic consequence of a medical condition, substance abuse, withdrawal. So it's not, now dementia could be underlying the condition. Sometimes a delirium is actually the first presentation of what is later to be described as a dementing disorder. But that's not what it's meant to be. It's not a dementia. So it's usually somebody who gets hospitalized because of an infection or some other medical problem that's out of control and affects their cognitive state. In DSM-4, the previous version, it was the essential feature was a disturbance in consciousness, which kind of makes sense, but when you get down to it, it's kind of hard to describe what consciousness is. So, in DSM-4, people talked about disturbance of consciousness. DSM-5 now translated that into disturbances in awareness or arousal. Again, kind of soft-ish, but I think more medically definable in terms of what constitutes awareness and what constitutes arousal. So that was really the big change. Whole host of other features I won't bore you with, but that was the change that went on with regard to delirium. So the rest of it then pertains to what's called neurocognitive disorders now. And here the plan was to essentially describe the syndromic features of mild neurocognitive disorder, major neurocognitive disorder. After you've described the syndrome, then you ask the question, what is causing the syndrome? What is it due to? And the charge for this group, of course, was that we're dealing with a whole host of disorders, not just Alzheimer's disease. And while Alzheimer's disease is sort of the major player in the whole chapter, there certainly are a whole host of other disorders, including HIV, head trauma, and all kinds of conditions that had to be subsumed. Hence, the terminology had to be a bit more broad than what we would just see if we were talking about only the Alzheimer's disease spectrum. Come back to that a little bit later. So, the other major change, of course, is that in DSM-4 and previous versions, we were really mostly talking about disorders at the dementia level, so that degree of severity. And now in DSM-5, a major focus has shifted to, as we heard this morning, sort of the pre-dementia phase of these disorders. So if you want to call it mild cognitive impairment, it's kind of that stage. So we're really shifting now and adding a whole new domain, set of domains, if you will, to the spectrum of neurocognitive disorders. And you may have heard about all the press around DSM-5 and a lot of uproar, mainly pertaining to other disorders, childhood disorders and the like. But actually there was a little press directed at this, that the detractors of DSM were saying, well, gee, mild neurocognitive disorder, it sounds like aging to me, and are these guys just trying to generate a new condition for the drug companies to have a target to treat? So expanding the market for drug companies. I mean, this was one of the criticisms and comments made about this. But as you can see, I think we countered to that by saying, no, this is the way the field is going. The whole field is moving toward earlier and earlier presentations of a whole variety of disorders, and so we tried to capture that with the term mild neurocognitive disorder. So, what major versus mild? What's the difference? Well, severity being one, of course, and when we're talking about cognition, it's degree of cognitive impairment to a certain extent. Independence. Let me explain this. By this, we mean functional behavior, essentially. So, a key distinction between mild and major neurocognitive disorder is, can the person function independently or not in his or her daily activities? With mild neurocognitive disorder, you kind of are inconvenienced, but you can still do it. Major neurocognitive disorder, now you probably need help. You need someone else to assist you in doing your basic activities. So that is a key distinction. Now, in the DSM lingo, they didn't want to use the term function. Function has a whole different implication for DSM. So they said, can you get around that some other way? And so it was sort of this independence or loss of independence that became a factor. Usually, the mild to major dimension, so to speak, was a continuum where mild would frequently move on to major, like in Alzheimer's disease. But again, because we were dealing with so many other types of disorders, that could not be a defining characteristic. For example, traumatic brain injury. A person with traumatic brain injury who has mild neurocognitive disorder may get better, need not go on to major, so you had to account for that. But if you want to think of it along a continuum, that was often the case, but it depends upon how it's applied to a specific underlying etiology. And then, of course, as I just said, it varies by etiology. It depends upon the nature of the underlying disorder. Another one would be vascular cognitive impairment. So you could have mild neurocognitive disorder due to vascular disease, and if you stop the vascular insults, the person might in fact get better. So all that had to be accounted for in the overall scheme. So cognitive domains. We tried to make some kind of a characterization of what cognitive domains we were talking about and then give a little hint as how might they be different in mild and in major. So we talked about the domains and tasks. So complex attention. In major, this would equate to an individual who could no longer sustain attention, especially with multiple stimuli. With mild neurocognitive disorder, there might be a subtle derangement here, but it generally would be, it took me longer to do my actions, but I still could do them. So again, a subtlety here, but probably important. With regard to executive abilities, same kind of thing. In the major subtype, you're probably abandoning more complex activities, where in the mild one, it's just going to take you more time, you're going to be less efficient, but again, you can still do it. Learning and memory, major forgetfulness, repeating a lot of information, forgetting a lot of recently acquired information, having some trouble with remote information as well. In mild, maybe recent events are slightly impaired, occasionally would repeat himself or herself, but this didn't become a major factor, yet it was a change from their previous level of functioning. Language, again, anomia, paraphasic errors in the major variety, might have some subtle word-finding problems, a change again, but word-finding problems at the mild stage. Visual constructive, visual perception, major, not driving, having difficulty navigating, maybe at the milder form, subtle findings, difficulty maybe interpreting a map as well as you formerly did, but again, with some effort, you could, in fact, do it. Then there was another domain that was added, again, to try to be inclusive of the other disorders that we would encounter, and that's called social cognition. This is soft, a bit squishy. What are you talking about here? But this was necessary when we're starting to talk about disorders outside of Alzheimer's disease. So think of frontotemporal dementia, frontotemporal degeneration. The earliest presentation might very well be a subtle change in personality and inability to assume another person's perspective. an inability to know what's socially appropriate and inappropriate in the context. It may not be cognition. Now, the person may have language problems, may have attention executive problems, but those may be further into the disorder. The absolute presenting features might be more behavioral, so to speak. So social cognition was meant to try to capture some of these changes. Also, dementia with Lewy bodies. Sometimes there are behavioral changes early on rather than cognitive changes. So again, to try to capture all these other disorders, the array of domains had to be broader than we typically consider. So this schematic, I think, simplified to a great extent, but this sort of captures mild and major neurocognitive disorder. So the two continua here, cognition with some kind of arbitrary distinction here. Again, it depends on the person, depends on the person's background, their ability, where they are, their education, etc. But there is a degree of more cognitive impairment here. And then that independence notion I mentioned with regard to function. There's an interruption there in function. So, mild neurocognitive disorder sounds like MCI in most respects. Cognitive decline, single cognitive domain impaired, usually, although there can be subtle changes in other cognitive domains beyond a single. Memory, say, frequently in early Alzheimer's disease, but you might get a little executive dysfunction. You might get a little language dysfunction early on. And then largely preservation of independence at the mild stage. You move over to the major, cognitive decline, yes, it's more severe. Cognitive impairment now, significant cognitive impairment in one or more, often multiple cognitive domains. This is where I tried to hold out and lost in my discussion. The committee ultimately said, gee, you could have one cognitive domain severely impaired to call it major. I didn't think that was very likely. I thought if you get one domain that's severely impaired, odds are there's another domain that's somewhat impaired as well. Anyway, I lost. And because the rest of the world, when we talk about dementia, usually talks about two or more cognitive domains being impaired. And I thought it'd be best for DSM to be consistent with that part of the world, but for what it was worth, this is the way it came out. Otherwise, I mean, it's essentially dementia. And note that the terms are still preserved in the manual. That is, dementia is not taken out. So if you go back to my first slide, which was the title slide, I put a question mark at the end. It's renaming dementia. Yeah, sort of, but not really. In other words, you still can use the term dementia if you want to. And then finally, loss of independence is a defining characteristic. So, what are the criteria then? Major neurocognitive disorder. Again, dementia is still a term that's used. Cognitive decline, usually in one, but usually two cognitive domains. How do you know that? You can tell the decline. If you have serial evaluations, that's great, but often we don't on our first encounter with a patient. So how do you get that information? From the patient, him or herself, or from somebody who knows the patient well, or you as the clinician observing them saying, now something's going on here and this likely represents a change because this is a university professor who's now having difficulty with cognitive function. And when you measure it, so you actually evaluate the person one way or another. Neuropsychological testing is often very helpful, or your office-based examination, whatever you choose. Now, I'll tell you a little sidelight here again of the politics involved in developing this. We really felt, and there were some individuals on the committee who felt strongly about putting down some rather hard metrics for this. So, for example, the major neurocognitive disorder would be at least 2 standard deviations below that person's appropriate normative behavior. A woman of high school education, 72 years of age, with this occupational background, bingo, she's now performing 2 or more standard deviations. But then you have to realize that this manual applies to anybody in any kind of clinical situation, so that you say, what if you don't have norms available? What if, when we are applying this in East Black Duck, Minnesota, there isn't a neuropsychologist around to corroborate or perform formal testing? So we had to back off give sort of examples of ranges of performance, but stop short of putting any kind of hard data in with regard to numbers. And again, the other essential feature is that it has to interfere with independence and activities of daily living for this individual, and then in the DSM form, not delirium and not due to another disorder. So that's basically major neurocognitive disorder without specifying etiology. Now, mild neurocognitive disorder, why do it in the first place? Well, as I was saying earlier, mild cognitive impairment, which is kind of the analog, has really become quite popular in the literature for a variety of disorders. We're trying to recognize these disorders as early as possible. We may be able to intervene earlier and with a greater outcome at the end, and of course for clinical trials we need to attack these disorders earlier rather than later. So with that as the rationale then, the criteria become, again, a cognitive decline, and this is basically obtained in the same fashion from the subject, from an informant, or from the clinician. And here at this level, I wouldn't dismiss, not that we ever dismiss what the patient says to us, but I think it might be more reliable and valid at this point in the very mild early stages that in fact the patient is aware of a change in his or her cognition. And again, this has to be accompanied by cognitive deficits, real cognitive deficits, again, appropriately geared for that particular individual. And then the other DSM things that, except for B there, I'm sorry, not interfere with independence. You may need greater effort to do the work, but you still are able to do it. You still are able to function independently. Now, so that's the syndromic level. Now the next step goes to what's the cause? What's the etiology of this syndrome so that you will end up with mild neurocognitive disorder due to one of these, major neurocognitive disorder due to one of these. And now it becomes very variable as to how you fulfill this next part. So I'll give you an example of Alzheimer's disease as it stands in 2013. But these other disorders may have a whole host of other conditions. Like, for example, substance abuse and medications. Well, to get to that classification, you have to have some evidence that the person is misusing certain substances or medications. Traumatic brain injury. To get in the game, you have to have had a traumatic brain injury. Now we put the syndromic definition on you. Similarly with HIV/AIDS. You already have HIV/AIDS. Now we're seeing if you have cognitive disorder. So, but in Alzheimer's disease, it's a little bit different. And I'll show you that in just a minute. Again, what we were hinting at this morning and what Adam was talking about with regard to imaging parameters, amyloid imaging and the like, these are certainly coming on board, but may not be at the level right now that we can say this is part and parcel of the definition of Alzheimer's disease. Okay, we're getting there, but we're not there yet, and especially for a manual of this magnitude. So, what's Alzheimer's disease? We've been talking about it all day. We know what it is, and now we have to superimpose this onto the clinical syndromes. And again, the role of imaging and biomarkers is certainly there, but has still not been formally incorporated. So, to call it Alzheimer's disease, major neurocognitive disorder, first of all, you have to meet the criteria for major neurocognitive disorder. Mild has to meet the criteria for mild neurocognitive disorder. Now, once you've done the syndromic, then you can add on the etiology, but there are different levels of certainty. Is this, in fact, Alzheimer's disease? Again, without the definitive biomarkers yet achieving that status, how do we know it? Well, for major probable Alzheimer's disease, you can get there in two ways. One, if you have the syndrome of major neurocognitive disorder, you have a genetic mutation, bingo, you're there. It's Alzheimer's disease. Without a genetic mutation, of course, those are fairly rare. You need all three of these conditions, memory plus another domain, progressive disorder, and no additional. So you haven't had a major stroke, you haven't had other issues that could contribute. If you have those features and the syndrome of major neurocognitive disorder, then it is probably due to Alzheimer's disease. Now, on the mild side of the house, we were much more conservative. That is, at what point do you say mild neurocognitive disorder, say MCI? At what point do you say it's due to Alzheimer's disease? Well, as we saw this morning when Adam showed the amyloid imaging data, half or more of the people who had this A syndrome of mild neurocognitive disorder did not have amyloid in the brain. So you have to be very careful. We can't overcall. We're not going to label somebody, because if you say, I think you have mild neurocognitive disorder due to Alzheimer's disease, and you're wrong, well, you can't be wrong, because all they hear is Alzheimer's disease. So you have to be quite certain that you're dealing with it at this milder stage of symptomatic presentation. So the only way you can get probable is if you have the genetic mutation. So you're in one of these families with an autosomal dominant mutation. You have the mutation. You have mild NCD. Bingo, it's Alzheimer's disease, just at the milder stage. However, to get possible now, you have these other clinical features. So you have mild neurocognitive disorder. You have memory disorder, it's progressive, no additional, but we still are going to play that down to only possible because it's not absolutely certain that this is going to play out that way. So this gets a little tricky, and I think explaining this, when clinicians understanding it and explaining to patients is going to be a bit of a challenge. But it does represent, again, moving the clinical spectrum back to milder and milder stages. Now, just to put this in context, there are other criteria out there. There's the Alzheimer's disease spectrum by the National Institute on Aging and the Alzheimer's Association. Adam talked a little bit about that this morning. I'll say a couple words now. And then he talked about the International Work Group, Prodromal Alzheimer's disease. So how do these all fit together? You saw a version of this slide this morning, and I put this up again because this is sort of the theoretical background of what leads to the use of biomarkers for documenting the Alzheimer's causality of the neurocognitive disorder. And again, amyloid being earlier, then you have tau, the other markers, and cognition and function are way down here. This is sort of the notion now that the new criteria by the NIA Alzheimer's Association have broken the spectrum into 3 phases. We formerly only talked about dementia due to AD. Now we talk about MCI due to AD, and we talk about even a preclinical stage. And DSM-V is addressing this and addressing this. It doesn't even want to go there and probably shouldn't at this point in time. So, busy slide, don't worry about it, except to say that there are gradations of dementia due to AD, like major neurocognitive disorder, and here's how the biomarkers may have contributed. Again, so you could have intermediate probability, could have high probability for an atypical presentation, or a low probability. Now this is interdigitating the clinical symptoms with biomarkers, but this is not accepted either. This is all still out there for research because we don't know how these biomarkers are going to play out. So DSM-V didn't want to get ahead of the field, and so it has not incorporated biomarkers yet into the mix. Similar kind of notion with MCI. So we have the clinical syndrome here, then we have biomarkers, A-beta biomarkers, neurodegeneration biomarkers, present or absent, changing the likelihood. This is uninformative, intermediate, and then highest probability, depending on how the biomarkers play out. And then just for completeness, I put this preclinical. This is the stage at which people are clinically normal, but may have a biologic predisposition to develop MCI and dementia in the future if these all play out. But this is all research right now and not relevant for the discussion today. And then prodromal Alzheimer's disease by the International Work Group is largely a memory deficit supported by biomarkers, and now they're leaning toward biomarkers that are of an amyloid basis. So they've had a couple of publications, 2007, 2010, Lancet Neurology. There's a third one floating around that's probably going to be out very soon, but it'll essentially be this. You need to have a memory deficit, and then that has to be supported by probably an amyloid measure. Well, let's look at an example. We can talk about this in the abstract all along. Let's talk about a case example and then try to apply the criteria, the NIA criteria and the DSM criteria. It's a 53-year-old woman whom I saw a number of years ago with a year and a half history of sort of loss of self-confidence. Husband was offered a job elsewhere. She didn't want to move, felt uncomfortable. I can't think. Rapidly forgetting in conversation now. Adult daughters have noticed that mom's not the same for the past year or so. Not understanding her reading very well, sleeping okay, concerned but not depressed. Family history, negative for dementia. 53-year-old, negative for dementia. Past medical history, generally good health, had a postpartum hemorrhage after her third child on a couple of medications and supplements. So kind of a non-plus presentation with regard to possible causes. So how does she test out? 53 again. This is like the mini-mental. 38 points, she gets a 37. IQ is sort of average-ish, 107, 97. Attention, concentration, she performs at the 50th percentile. Language, she actually does quite well. She's at the 90th percentile. Visuospatial function, she's at the 50th percentile. But memory is off the mark. So learning a paragraph, verbal information, she learned 17 pieces of information, recalls 10 after a half an hour. Visual information, she learns much more, 64, but retains only 21 of them after a half an hour. And on a 15-word list, her learning curve 7, 6, 11, 10, 8. After a half an hour, remembers only 3. So her memory is off compared to her other cognitive domains, which are average-ish or above average. So at this point in time, using the NIA Alzheimer's Association criteria, we would call her MCI for the clinical syndrome and indeterminate or uninformative because we don't know, we don't have any additional information at this point in time. But again, you as a clinician might be a little anxious making this call at this point in time because of her negative family history and her age. So let's get some additional information. So we do an MR on her, and the long and short of Cliff Jack does MRI scans and quantitates them in our laboratory. She's actually in the normal range. There's a little bit of atrophy in the hippocampus, but not enough to say this is an abnormal MR scan for her age. But we do an FDG PET scan. Again, Adam talked about these this morning. So in this depiction here, these are sagittal. We're looking at the right side of the brain, face here, back of the head here. And in this statistical formatting, the colors imply abnormal glucose utilization. So she's not using glucose in her right hemisphere in the parietal temporal regions, a little bit of suggestion in the left hemisphere as well. And here's the whole picture, here's the regular scans, here's the statistical rendering, and then we can put numbers on it saying where is she relative to where she should be, and in fact she is down for her age and against our laboratory normals. So then we do an amyloid imaging scan, and here, this is an axial scan now, and the redness implies that there is amyloid retention in these areas, tracer retention indicating amyloid in these areas. Anything greater than a 1.5 is felt to be abnormal. So in fact, she does have an abnormal amyloid imaging scan. So now, where is she sitting in the depiction? She has the clinical syndrome, but now the highest probability that this mild clinical syndrome is due to Alzheimer's disease because she has a positive amyloid imaging scan, she has a positive FDG PET scan. So she has evidence from both sets of biomarkers, and she has the clinical syndrome. So this is MCI due to AD. DSM-V would have called her mild neurocognitive disorder, MCI, possible AD, because again, she doesn't have the family mutation, so the only way you can get that is by the clinical characteristics. And again, DSM doesn't use biomarkers at this stage, so she would be called possible AD in their depiction. Okay, so we continue to see her annually. 2 years later, now she's progressed clinically. Now she's getting lost, frequent forgetting, no longer driving, somewhat despondent. Her cognitive testing profile now has progressed. Now she's down to a 32. What was 50th percentile is 25th percentile. 90th percentile is now 60th. 50 is now down to 25 and 30, and her memory performance has declined further. So she's declined functionally, she's declined cognitively over that time frame. Her MR scan, which was in the normal range before, is now atrophic and in the abnormal range. Her FDG PET scan has become even more hypometabolic in these areas, and now her ratio has dropped even more than it was 2 years earlier. Here's this full. And now her PIB scan, amyloid imaging scan, shows even more amyloid than it had 2 years earlier, so now the ratio is up to 2.7. So now she clinically has progressed to dementia, and she still has the positive biomarkers, so now she's probable Alzheimer's disease, highest probability dementia due to Alzheimer's disease. In the DSM framework, she's now major neurocognitive disorder, probable Alzheimer's disease, because she's progressed to major and she has enough evidence now to convince us this is in fact due to underlying Alzheimer's disease. So you can kind of match these together, and they sort of float along in a similar fashion. So again, this is the depiction now, I think, that you should keep in mind with regard to major and mild neurocognitive disorders. They kind of map onto the criteria that were developed by the NIA and the Alzheimer's Association. Hard to see this, and I apologize. This is the first time I've ever shown this. This is a work in progress, a figure for a publication that's coming out. I'll try to go through it. Maybe you can read it better than I can. This is the characterization of mild cognitive impairment, the amnestic form, the non-amnestic form. Now we take in green here and put DSM-5. DSM-5 is basically mild neurocognitive disorder, captures all of these that were previously depicted in MCI criteria. In orange now we put the criteria for MCI due to Alzheimer's disease, 3 levels, one being uncertain, intermediate, and high. And here we put together the clinical syndromes, the blue boxes. You bring those down and you add on. At the uncertain level, we don't have any information from biomarkers. At the intermediate level, we either have evidence for amyloid or evidence for neurodegeneration by MRI and PET. At the high level, we have evidence for both amyloid deposition and neurodegeneration. So we take the clinical syndrome, we graph this on, and we now have high level. For the international work group, the prodromal Alzheimer's disease, you're probably just dealing with this because they only talk about the amnestic presentation with amyloid. So this is meant to try to, I realize it's hard to do this from a distance and all that, but this is meant to try to bring these different sets of criteria together for you to get a feel for how they really mesh and how they are intertwined. So last slide. So DSM-5. I think it's new terminology, but I don't think there's anything conceptually different from what you've been dealing with regard to dementia or MCI. MCI due to AD, dementia due to AD really can be subsumed under the DSM-5 terminologies, as I tried to show you with that example. Now, going back to the title of the talk, is it renaming dementia? Maybe yes, maybe no. The adoption of the new terminology will be dependent upon the field. If the field wants to use major neurocognitive disorder due to Alzheimer's disease, go ahead, you can do that. If you want to use dementia due to Alzheimer's disease, go ahead, you can do that. So now I say that without knowing exactly how the ICD 10 and 11 are going to incorporate this. But basically, if we as a field still think that these older terms are useful, our patients are comfortable with them, we're comfortable with them, the literature is out there on that, continue to use them. That's just fine. And somebody behind the scenes will translate to the new DSM-5 criteria. But basically, I don't think there's a major difference between what we've been doing. So let me stop there, and thank you very much. I'd be happy to try to answer them.
Okay, we have time for a few questions if anyone wants to ask Dr. Petersen.
There should be one question out there, and the question is, why is DSM 1, 2, 3, 3R, 4, 4TR in Roman numerals, and DSM-5 is in Arabic numerals? So that's the big question. And supposedly, actually, if it works out, it's important. And that is, they wanted to go to an Arabic numeral like 5 because there may be a 5.1, a 5.2, etc. There may never be a DSM-6. And the idea being that in the electronic era, while this manual is still printed in the hard copy, it's also online, and it's conceivable that an area within the manual may be updated prior to other areas, depending on how the field moves. So, for example, our field, dementia, neurocognitive disorders, and all that, may actually go to 5.1 if biomarkers are accepted by the field as part of hard diagnostic criteria. Then one can see how these criteria might in fact be updated in a piecemeal fashion. So that's the...
I have a question. What do you think the primary driving factors are for development of Alzheimer's at 53, such a young age?
Well, it's a good question. So why did that particular young woman develop the disease? Apparently did not have a family history. I mean, I don't think there was anything in her lifestyle. I don't know if there was some kind of mutation, genetic influence that happened. I really don't know why she'd be that unfortunate.
What about the role for ApoE in terms of this diagnosis? It seems like
Yeah.
it was silent.
Yeah, you're right. ApoE was not really considered in either of the formulations, whether they be the Alzheimer's Association NIA criteria, and I think people felt that it didn't add all that much to the clinical diagnosis. Now, that may change too, but in fact, if you knew that, it isn't going to alter your diagnostic consideration a great deal. And one of the members of that was Deb Blacker, who's the geneticist. So.
Okay,
Good.
thank you.
Thank you.